This is a presentation on the neurodegenerative movement disorder Parkinson's disease, and in it we're going to talk about the background of it, the clinical presentation and some differential diagnoses, and then investigations that you can do, and then the management. And to go with it, there's a handout, there's some further reading and YouTube links at the end, and also some suggestions for things to look out for in the wards in the handout. Starting with the background of Parkinson's, the prevalence is about 0.3% of the population, rising to 1% of those over 60 years old, and the incidence is 8 to 18 cases per 100,000 person years. So to think about why people with this disease get their symptoms, it comes down to the basal ganglia in the brain and the direct and indirect pathways that they're involved with. So the direct pathway essentially enhances movement, and it's an accelerator for movement, whereas the indirect pathway can be thought of as perhaps like a brake on movement, reducing movement. And the substantia nigra pars compacta is something that it helps the direct pathway, it enhances it so that movement is encouraged. However, in Parkinson's disease, this part of the brain is degenerated, and therefore the direct pathway isn't enhanced as much as it normally would be, and the indirect pathway it overcomes the direct pathway to some extent, and movement is therefore sort of discouraged, and you get this slowness of movement and bradykinesia seen in Parkinson's patients. And this degeneration of the substantia nigra pars compacta is thought to be due to Lewy bodies, which are a histological change due to aggregation of abnormal proteins called alpha-synuclein. As to why certain people get Parkinson's and others don't, well, around 85% or even more than that of cases are thought to be idiopathic with no known identifiable cause. However, a small handful have an identifiable cause, such as mutations in the Park1 to 11 genes. Things that increase your chance are pesticides and heavy metal exposure, and things surprisingly that decrease your chance are smoking and coffee. Although Parkinson's can present in a number of different ways, everyone that has the disease will have something called Parkinsonism, and that is bradykinesia plus one or more of rigidity, tremor and postural instability. So bradykinesia is just a slowness of movement, and that's actually what gives rise to the expressionless face or hypomimia that can be seen in some patients. Rigidity is just an increased tone, and the tremor seen is a resting tremor that often looks like someone's a pill rolling sort of movement with the hands. Postural instability can also be seen, and that might be where the patient has had a number of falls recently. When tremor is superimposed on top of rigidity, that can give rise to something called cogwheel rigidity, which on examination can be seen by flexing and extending passively at the wrist joint. So they're more the motor symptoms of Parkinson's. There are also some non-motor features which can sometimes be overlooked. So there's cognition, such as dementia later on in the stages of the disease. Mood can be affected in the form of depression. Patients can have trouble with sleep, such as vivid dreams, or even acting out their dreams and sort of lashing out in the night, which can be quite distressing. They might find that their speech is a bit quieter, also they can't quite articulate their words as well. They might have autonomic features, so constipation, postural hypotension, sweating, or even increased salivation. So there are some more features to look out for in the handouts. It can help to break down Parkinson's into stages. So a simple one that clinicians sometimes use is starting with diagnosis, where the patient has just found out they have the disease, followed by maintenance, where they're just being treated initially and the symptoms that tend to be under control, and it's quite a good part of the disease course. And then there's the complex aspect, where perhaps the symptoms aren't being kept at bay quite as well, and therefore the management regime needs to be altered. And this can be quite a stressful time, where also psychological aspects of the disease can come into play, and this can be a burden on on the patient and carers. In the palliative phase, that's more the latter stages of the disease, where the priority is just to keep the patient as comfortable as possible. And things that can sort of enlighten us about the prognosis of certain patients are the dominant motor feature that they have. So if they have more of a tremor dominant Parkinsonism, then that tends to give a better outlook. and also earlier age of onset of the disease, and also a better response to levodopa treatment also indicates a better outlook. When considering a diagnosis of Parkinson's disease, some other things to consider are Parkinson's plus syndromes, such as multiple system atrophy, which has quite pronounced autonomic features and can also cause cerebellar dysfunction. In progressive supranuclear palsy, the eye movements are affected and therefore they should be assessed to help exclude that. And in corticobasal degeneration, the patient can have apraxia, which is difficulty with purposeful movements, and also there's more pronounced asymmetry, so the motor symptoms tend to be more on just one side of the body. In Lewy body dementia, the dementia is the key aspect, which happens much earlier, and the motor symptoms tend to be more bilateral, evenly distributed. In vascular Parkinsonism, it's the lower limbs that tend to be much more affected, and drug-induced causes can be hopefully alluded to by taking a good drug history, looking for things, for example, like extrapyramidal side effects from antipsychotic drugs. Normal pressure hydrocephalus you can help to look for that by asking for the classical triad of symptoms, and there are some metabolic causes of Parkinsonism such as Wilson's, which might be helpful to look at copper serology, and also heavy metal toxicity, where an occupational history might be helpful, for example if the patient used to be a welder. And you can see from this list that it's quite a clinical diagnosis, Parkinson's disease. It's helpful just to have a really good history and examination, and usually advanced tests and imaging aren't normally needed. However, imaging can be useful, and when it is, for example, DAT scans can be used to look at dopamine activity inside the striatum to exclude essential tremor, and MRI scans can be used for a number of reasons, for example, to differentiate between Parkinson's disease and the various Parkinson's plus syndromes. So if we look at the medical management side of Parkinson's disease first, and start with the treatment for the motor symptoms, then there's levodopa, which simply replaces the dopamine that the substantia nigra is sort of supposed to provide but isn't because it's failing, and so the levodopa keeps those levels up. There's also dopamine agonists, which imitate the dopamine and act on those receptors as if they were dopamine. There's COMT inhibitors, which prevent metabolism of dopamine and keep those levels high, and monoamine oxidase B inhibitors do a similar thing, preventing modification and therefore degradation of dopamine, keeping those levels up. Important side effects with Parkinson's drugs to mention are nausea and postural hypertension, and especially initially these may however get better after a short period of time with the treatment, or they may not. And there's also important to mention impulsivity. Patients can do things that they otherwise normally wouldn't, such as gambling and risk taking, and it can be quite important to mention that could be something to look out for to patients. At the bottom of the page I've put a graph to try and illustrate the difficulty in titrating the levels of, for example, levodopa throughout the course of the disease, and the sort of challenges that presents. So early on in the disease you can see there's that sort of honeymoon period where things are good and the levels are within what's necessary to keep the symptoms at bay for the patient. And you can see though that with the black line, if you were to continue with this dosage regime, then later on as the disease becomes sort of more complex in the complex phase, then you're just going to get these off states and the patient might have freezing episodes where they just can't move. And so to avoid that, you would want to do what's in the red line, so titrating the dose to fit the new sort of requirements for the patient. And obviously this presents difficulties. If you get the level too high, then the patient can have dyskinetic episodes where they're just having involuntary jerky movements that they have no control over, and they don't want that. So and equally you can still get these off states when you just don't quite get the level right. So that is quite challenging as the disease progresses. Other therapies to consider in the later stage include subthalamic nucleus deep brain stimulation if the patient's eligible for it. Also there's apomorphine infusions, more for the really severe off states the patient might get. And then there's duodopa, which is an intrajejunal infusion that the patient can have in the later stages. In managing Parkinson's disease, the multidisciplinary team likes to get involved right from the start to provide the best care for the patient. And with the whole multidisciplinary team, it's easier to look at the non-motor features of the disease and how to tackle those. And typically the approach is that if there's a sort of drug-based way of solving these problems, then that's the better approach to take initially. So, for example, with sleep problems, it'd be good to advise good sleep hygiene as opposed to going straight to, for example, sleeping tablets. And with depression, if the patient is very low, then CBT might be the best way forward initially. With speech difficulties, there's something called Lee-Silverman voice treatment, and that's a sort of non-drug-based way of getting the speech to become better. And with a high-fibre diet, that can be one way of tackling constipation, or increasing exercise, and even like prune juice intake. And if the patient is anxious, then you might encourage relaxation therapy. So the general way of looking at the whole thing is, if you can get away with a non-pharmaceutical way of tackling the problem, then go for that first, and then maybe go for sort of laxatives for constipation, and maybe anticholinergics for hypersalivation later on down the line if nothing else can be done for it. Thank you very much for listening, and thank you to Dr. Rob Skelly and Dr. Jonathan Evans for some really helpful advice in putting this presentation together.